This is our iliofemoral joint case study by
Emma,
Diana,
Rachel, Sam,
and Maddie. Meet Greg. Greg is an all-star hockey player who had an unfortunate injury to his right hip. He mentions pain in his right anterior groin, an odd clicking sound, and some pain when sitting. After further testing, Greg also showed instability when standing on his right leg. We want to get to the bottom of this injury to get him back on the ice as soon as possible. A few injuries come to mind when we hear Greg's symptoms. But first, let's do a bit of a review on the iliofemoral joint, or better known as the hip joint. Remember that this is a ball and socket joint formed by the articulation of the head of the femur and the acetabulum of the os coxae. Because this is a ball and socket joint, the hip has a wide range of motion and makes movement possible in all planes. While this seems very convenient, it leaves room for damage and wear and tear. When taking a careful examination of Greg and his symptoms, we narrowed it down to 4 possibilities: iliac contusion, piriformis syndrome, iliopsoas bursitis, and a hip labral tear.
We evaluated the typical symptoms of each injury and compared them with Greg's symptoms. With the iliac contusion, it is common to see swelling and muscle spasms as well as hematoma. Iliopsoas bursitis often comes with radiating pain down the front of the leg, a tender quad, and often popping noises. In piriformis syndrome, there is butt pain, radiating pain down the leg, and often numbness and tingling in the buttocks. Finally, a hip labral tear includes symptoms of pain in the groin or hip, clicking sounds, and it is very common in hockey players. We decided to diagnose Greg with a hip labral tear. But first, what is an acetabular labrum? The acetabular labrum looks like a ring surrounding the circumference of the acetabulum and attaches to its bony rim. The labrum is made up of both fibrocartilage and dense connective tissue. Its job is to help with the hip stability and reduce stress placed upon the hip. The labrum also keeps synovial fluid within the articular cartilage and reduces chances of bone-to-bone contact.
It is very common to see injuries to the labrum in car accidents as well as sporting activities, including soccer, golf, and Greg's favorite sport, hockey. It is usually not caused by one specific event, but rather repetitive hyperabduction, hyperextension, and hyperextension with lateral rotation. The image on the left depicts a labral tear. Let's talk about Greg's treatment options. His first possible treatment would be surgery. This arthroscopic treatment would cut away damaged tissue, and it takes about 6 months of recovery time. This is the most reliable treatment to get Greg back to 100% and get him back on the ice.
Depending on how severe the tear, physical therapy is also an option. It can help with range of motion, optimize alignment of the hip joint, and strengthen the muscles around the injury. Injections and prescription drugs can be beneficial as well. Corticosteroid injections, anti-inflammatories, and NSAIDs can also reduce pain and inflammation. We decided that arthroscopic surgery followed by physical therapy would be most beneficial for Greg's injury. First, let's look at a video that shows how arthroscopic surgery works. The second video depicts some of the physical therapy that Greg will undergo.
The labrum is the cartilage that surrounds the hip socket. It may tear as a result of athletic injuries, falls, motor vehicle accidents, or arthritis. Patients with symptomatic tears should consider an arthroscopic repair. The surgeon begins by placing the affected leg in traction to create room between the ball and socket of the hip joint. A needle is placed inside the joint under X-ray guidance, and a guide wire is passed through the needle. The needle is removed, and a metal dilator is passed over the guide wire to create a track into the hip. A small camera is then placed over the guide wire into the hip joint. The process is repeated to create a second access portal for the surgeon to perform the repair. A needle is placed anterior to the first in the hip joint, and a guide wire passed over the needle. Two dilators are used to allow for passage of larger instruments. A tissue cutting instrument, or shaver, is passed into the joint over the guide wire. The shaver is used to create room in the lining of the joint for the easy passage of other instruments. A blade is then inserted through a cannula and is used to free the remaining labrum from the hip socket. Once the labrum is completely detached, the underlying bone is smoothed to allow for easy reattachment. A suture is then placed around the labrum and brought out the cannula. A punch hole is created just above the rim of the socket, and the suture is secured to the hole using a push-lock anchor. For larger tears, the surgeon will use multiple anchors.
One of the main goals in phase 1 of rehab is to gain range of motion. We start with a hip range of motion exercise. Lying the patient supine with the hip flexed to 30 degrees, we rotate the leg clockwise for 5 minutes and counterclockwise for 5 minutes. I would also do this at 70 degrees. It is important to stay below 90 degrees of hip flexion at this point in rehab. Isometrics are also key during this phase. The patient lacks active range of motion and needs to strengthen otherwise. I would start with strengthening the glutes with isometrics by asking the athlete to lie prone and contract the glutes. This strengthens external rotators. Next, I would strengthen the adductors and abductors of the hip. Lie the athlete in a hook-lying position where they will squeeze a ball between their legs for adduction and resist a TheraBand for abduction. This can also be done in a prone position. Exercising the adductors by squeezing the ball, and the abductors with the TheraBand, holding for 10 seconds with each isometric contraction. Next, put the athlete in a dependent position. Have them extend the knee to strengthen the quad. The rectus femoris is important to strengthen during this phase. Next is double leg bridges. This combines a closed kinetic chain exercise and a range of motion exercise. The glutes, psoas, and core are strengthened.
Although Greg will need to wait 6 months to get back into his sport, the surgery will repair the injury fully and he can get back to his strength and flexibility through his physical therapy. It is absolutely necessary that Greg be patient with the process and allow the healing. He must also be diligent about stretching to continue to increase mobility and flexibility. When starting up physical therapy, Greg's exercises will include strengthening his gluteal, adductors, and iliopsoas muscle groups. It is also important to strengthen his hamstrings and quads to correct his overcompensation. Don't forget, although we are repairing the right hip, we need to pay attention to the left side as well.
We do believe Greg will have a full recovery, but he may need to take the season off for his hip to fully heal and repair. Not to worry, we suggest that Greg pick up a different sport that works different muscle groups while he was working to get back to being an all-star, injury-free hockey player.